Thank you for all people attending this symposium. I think that even from the question side, we need that our work is worthwhile in a perspective of analyzing DME as not a very simple disorder that we have done in the past, something that the therapy was just closing a pump, but analyzing a little bit more in detail about this. We have introduced the symposium as made by Professor El Asrar, considering that diabetic retinopathy remains one of the most important, probably from the numerical point of view, the most important cause in the working population, 10 million people at the moment around the world. And as pointed out in previous presentations, there are in this disorder, and I hope that the previous presentation has clarified a little bit this concept that the pathophysiologic pathways are not just related to the changes in the permeability of the capillary bed, but also there are some new actors working on this modification of the permeability. And unfortunately, from the point of view of the treatment, as again underlined by my co-chairman, the story is based on the fact that the therapy we are doing at the moment, the so-called gold standard therapy, is providing unpredictable results, as shown in the literature. And the lack of the biologic imaging versus what happens inside the eye, really, in human eyes, not in models, the proof of concept we have discussed. This is an old story, but it is a current story. We are debating about the results of the different treatment modalities, in particular, not the way of providing drugs directly inside the eye, but the competition between the different molecules inside the eye and results. But unfortunately, up to now, the real-world scenario and the real-world data are showing us that after the first year of treatment, an important proportion of patients treated with the gold standard approach are not really responding to the treatment. And there is, as shown before, a progressive deterioration inside the retina, and particularly in the middle part, in neuronal part. And the conclusion is that at the end of the story, the visual function is decreased. So the limited response to the current treatment has moved up to search for something else. Something else, when you perform a medical treatment and you have no success, you need to go back and look at the pathophysiology. Where is the point where I was wrong in my way? Okay? We are targeted at the moment with the current drugs at the level of the retina vascular beds, or the plexuses, as we are more correctly speaking now with the use of OCT angiography. But we have lost the concept, and it has been shown during this symposium, and particularly focused on this topic, that there are a lot of players inside the retina, and most of the retina is not vessels. And so the other cells cannot be considered just passive actors of this phenomenon. When hyperglycemia involves the retina at the beginning of diabetes mellitus, there is a disaster inside the retina, and which is perceived initially not by the vessels, but the other cells. There is, as shown and demonstrated by previous presentations and references from the literature, a hyperactivation of Muller, a hyperactivation of glial, and derangement of the metabolism of the nervous system. So, moreover, we have some more limitation at the moment. Both Enrico has shown the possibilities offered by OCT and OCA to integrate our imaging modality. And he correctly divided the influence of diabetes in the inner and outer part of the retina. We have not discussed enough, I think, up to the moment. The concept of the quantification of these parameters. We cannot still work on visual acuity and thickness of the central part of the retina as the only two parameters we have to judge what happens in the retina after our treatment. It has been shown that we have other parameters. As correctly pointed out in the discussion by my co-chair, if I can measure the parameters, I consider a sign of a phenotype, one of the at least two phenotypes now appearing as a new definition in DME. Personally, I'm not convinced, but a very interesting question we had, that diffuse and focal is still something which is important in the new pathophysiologic approach. But I think that this is an example, for example, of a case where there is a prevalent influence of the fluid permeability. We can say this is a patient prone to be treated with anti-VEGF, in particular since the beginning, with relatively good success. But this patient, for example, where there is a large amount in red of intraretinal fluid, but there are changes at the level of the outer part of the retina, meaning subretinal detachment, which is a clear-cut sign, as in the literature shown, because the authors, a Japanese group, sampled the vitreous, in this case, of this patient, and they have shown that there is a very high pathologic amount of cytokines inside his eye, much more as a rate versus VEGF. Or the change at the level of the number of hyperreflective foci, which now may be easily quantified. This is a patient where probably the approach with a standard anti-pure, what I call anti-VEGF, is not enough. Moreover, I am driving your attention to this very recent and very important paper I consider. This manuscript published 1-2 months ago in IOVS is showing that when we are discussing about our treatment anti-VEGF drugs, we are discussing which side of the vessels, the retinal or the choroidal, because there is an influence of the choroid to the different components. The diabetic choroidopathy is not completely open to the discussion because we are not so easily able to see the pathophysiologic changes in the choroid. But what we need to know that is the response of the two parts of these capillary beds is different. It's different depending on the molecule. It's different depending on the other parts of each molecule. So the new approaches is offering something new. And as shown before, you see these examples. These patients with DME were treated along 1 year and followed sampling the aqueous humor every 3 months. And you see that these three intraocular biomarkers or microglial activation are going toward normal in a long time because they were not injected really, but the disappearance and the maintenance of the no edema depends, for example, by these factors and the players. The part dedicated to the therapy at the moment by this short presentation is shorter, because we have a lot of something new appearing, I think, and probably in the near future. This is the story that they call the pure VEGF family, are those drugs which have a pure anti-VEGF effect, but there are other new or relatively new drugs. The influence of the placental growth factors has never been considered in the past. And when we are treating, for example, we are with aflibercept, we are inhibiting both VEGF and placental growth factor. And now we have a new drug which is inhibiting angiopoietin 2. And according to the people who worked on this topic, angiopoietin 2 is quite relevant and coupled with the VEGF to increase the permeability phenomenon, but not necessarily as the only one. And last but not least, we have neuroinflammatory cascade we are discussing since the beginning of the symposium, which may be modulated by the use of corticosteroid, for example, as underlined by Professor El-Asrar, which is not, which should be used when you have no success on one side, or when you decide that the inflammatory component is much more than the other one inside the eye. And the second point is that the immunomodulators. Immunomodulators mean that even the new drugs which are presented to us as anti-VEGF are really probably have other properties about this. And I would like to conclude my short presentation remembering to everybody, because we have even yesterday or some in other meeting discussion, please do not never avoid the loading phase. The loading phase is absolutely necessary. We are a little bit disturbed because we were 5 injections with one drug, 3 injections with another one, 4 injections with a new one. It depends in this case by the work done in their lab by the different companies. We need to follow the indications. But in any case, the loading phase is essential for the final results about this, as is essential the first year of treatment. So you see that just to remember that my words are not just voices, that 40% there is persistent DME in major clinical trials. And during time, we need how the work is proceeding, still working, not just as I told you, with the thickness probably in the future, but more quantitative data about this. We discussed about the players and the different activities of them. The enthusiasm of some researchers is demonstrated by this quotation, where the new drug appearing in the market, the last one, the faricimab, has been now, seems to be not only an anti-VEGF, but also as shown there, anti-inflammatory and neuroprotective. So these are 2 words for the DME in particular, or even the very poor, I can say, laser, particularly subthreshold micropulse. We already demonstrated an immunomodulatory activity as discussed. So in conclusion, the precision medicine approach is an approach completely different from a standard way of treating. The standard way of treating is not personalized medicine. And even in ophthalmology, we need to move from the standard treatment to a personalized approach as made in other areas of medicine. Thank you very much for the attention.
Thank you very much, Professor Medina. Now we'll open the floor for discussion. Any questions?
Thank you, Professor Medina, for this. I'm here. Thank you very much for this lecture, but I'd like to mention something. It's not a question if you believe it or not believe in the focal or diffuse. It's a question of videos, multiple presentation, and you may read it in the Retina Journal, July, of all the data with all the references that are based on this and the outcomes of the surgeries. And it explains so much of what happened before. The lack of success of the laser in one side because of the traction. The good success because of the non-tractional. The injection even, even the DRCRNet in the 5-year extension study in 2020 say in the abstract that they suggest to move to another system, to long-lasting therapy. They by themselves, but we continue with biosimilar and so on. So we have to stop.
Okay.
Look at this recommendation.
Can you please give a specific question, Professor Medina?
Question, it's a comment to add to the discussion. It's not answering this question.
I thank you very much for this observation. I think it's just a problem of definitions. And in the history of medicine, in the history of ophthalmology, even recent history, definitions are slowly changing. I agree that you are discussing about 2 manifestations, particularly with the previous way of analyzing the retina of diabetic macular edema. The concept that I underline personally, that diabetic macular edema has different phenotypes, may be more or less the same that you are saying with a different approach, okay? So we can say that diabetic macular edema is not a pure, single, simple entity, okay? Independently how you call them, it's important that you realize, that we realize, that inside this definition, there are different disorders. What I personally call the spectrum of DME appearance. And based on this, we are able to address our more detailed definition and treatment according to this. Thank you.
Thank you very much. With this presentation, we can conclude the session. I would like to thank the speakers for outstanding presentation and the audience for the helpful discussion.
Thank you very much.
Eduardo, you are moving.
At Apellis, we are lighting the way forward, committed to addressing geographic atrophy, or GA, which is the most significant unmet need in ophthalmology, as there are currently no approved treatments. Join our journey. At Apellis, we are lighting the way forward, committed to addressing geographic atrophy, or GA, which is the most significant unmet need in ophthalmology, as there are currently no approved treatments. Join our journey.